Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. In this broadcast, we're going to take a look at minor head injuries. Dr. Roger Swift and Dr. Orla Lyons are emergency physicians, and they joined Dr. Scott Teasdale and spoke about the management of head injury.
Welcome. Orla, Roger, thank you very much for coming in today and talking about minor head injuries.
Pleasure.
So the focus of today is on minor head injuries. But I just thought we might briefly start with, if you like, a definition of minor head injury and briefly just cover more major head injuries. So Roger, is there sort of any major, reasonably easy definition of minor head injury?
Well, the short answer is yes and no.
Yeah.
When you look at the studies when they're talking about minor head injuries, generally speaking, they'll be talking about someone who's had an injury to their head, and we're talking about blunt injuries, has had either a witnessed loss of consciousness or amnesia, or seen to be confused or disorientated for a period of time around the time of the injury. In addition to that, with the Glasgow Coma scale is GCS of 15, 14 or 13, no less than that.
Yeah, definitely at the higher level. Once we get below 13, we're going to the moderate range, and then...
So as soon as we get
less.
lower GCSs, we're talking moderate to severe head injury.
That's right, and then once down, with GCS 9 or less, we're definitely in the severe category.
Yeah.
So I agree with Roger. So any form of blunt trauma to the head that's associated with a disorientation or an amnesic period is considered as a mild traumatic brain injury. And then we have to worry about any sort of post-concussion syndromes after them as to whether we grade them a little bit more closer to...
So if we just deal with, just quickly, with major head injury. So if someone's got a low GCS, like below 13, below 9, then clearly that's fairly straightforward for rural practitioners. Those patients all need to be resuscitated, if you like, assessed and transferred out. Would that be right? Yeah.
Well, it might be harder for rural practitioners if they're actually at the football game when it happens, because obviously someone's knocked out, then they're going to have a low GCS to start with. So
I mean, persistent low, I suppose.
So and how persistent is persistent? If someone gets knocked out, you expect them to regain consciousness within several minutes and sort of return to at least a GCS of 13 or above over that period of time.
So by the time someone gets from whatever the injury is, a fall or a sports injury or something, and then they get to your local emergency department, if they've got a GCS below 13, that normally means that they're in trouble?
Yes.
Or,
Okay. The only other trick to it for minor head injuries is that, particularly when it's unwitnessed, is some people can't tell you whether they lost consciousness, they can't quite remember what happened. They think they do, but they're not sure. And so, from my point of view, my presumption is if they're not sure, then they have got a minor head injury. And you occasionally get old people are particularly good at sort of covering for any problems that they had. So they'll often swear, "No, I'm fine. It's all okay. I didn't lose consciousness." Old people, particularly, take things with a pinch of salt and have a very low threshold to at least observe them.
I'll just bring you back to the severe head injuries that I'm talking about in the sporting situation. Just one thing, if I was working in the rural community, to be aware with is basically to apply the C-spine airway breathing circulation modality. So if somebody is knocked out on the pitch and doesn't regain consciousness, I would definitely go down protect the C-spine, assess your airway breathing and circulation prior to transferring. That's something that we're working very hard on. I know it's definitely established amongst, because all the rural trainees would be involved in the same ACLS and all the trauma guidelines that we're all involved with in emergency, and I know that they practice that very, very well. But sometimes I think the emotion involved, particularly a lot of GPs, I know families will get involved with their own kids' sporting events, and your emotion might get overlay what's actually involved on the pitch, so if it's your son or your daughter that's had a concussion syndrome. So it's just really important to remember to protect the C-spine prior to transfer, whether it's if you've got somebody on site, a first aid with a proper C-spine collar and appropriate stretcher, or else rolling up some towels and using some tape, whichever you have.
So I suppose that makes sense, doesn't it? If they've got a head injury such that they're not conscious, they're confused, etc., then you can't assess their neck to clear the neck. So can you clear their neck then on clinical grounds once they're not confused?
I personally wouldn't. I don't know, Roger, would you? on clinical grounds if you're applying?
So I mean,
Someone's lost consciousness
and
for a
then
protracted period of
they
time.
get they get taken to the emergency department, and then now they seem to be not confused.
I think it goes back to, again, your mechanism of injury. If it was a high impact and they've fallen from a height, particularly, say, Australian rules, if someone's done a big catch and they've fallen down from a height, landed on their head, that person is not going to tell you whether they flexed their neck or extended their neck at the time. Obviously, they're unconscious at the time. So when they come through, you can make a good clinical assessment, and obviously you'd be quite relieved to find there's no neurological deficit, obviously, if they're fully GCS 15 and can comprehend. But I'm not sure I could make a good clinical decision.
So certainly you'd keep their spine in spinal precautions while their GCS is less than 15, and then once it's 15, you'd probably then, to try and clear their neck.
The issue with that, I think, is whether the patient is a good witness to symptoms or signs that they have. Can they reliably tell you it's sore when you're pressing in the midline of the cervical spine? Sometimes that's an instinct or comes from your experience, whether you feel the patient's reliable enough to do that if talking to you sensibly. And if they meet the other criteria for clinically clearing the cervical spine as with the Nexus or Canadian spine rules. I would. I mean, I have football players coming in. They've maybe had a brief period of loss of consciousness. They're talking to me sensibly, and they can cooperate with me. And I feel comfortable that if I press on their neck, and if it's sore, that they'll tell me that it's sore. It's only when Yeah,
I agree with you. The brief LLC, and they're fully cognitive when they come to you.
So they might have been obtunded at the time, but by the time they get to you, they seem to have a GCS of 15, etc.
No, I agree with Roger, definitely. Then you can make your assessment if they're fully cognitive and can answer all your questions appropriately on your neurological assessment and cooperate with the exam. You could clear them clinically. If
we're talking now just purely about minor head injuries, so they're our patients who are attending ED after having a head injury with or without loss of consciousness, and they don't have anything definitive to find on examination. But, for instance, their wife or loved one says they're just not right. What do you do for those patients?
I mean, it's easy. I work in a tertiary hospital. We get a CT scan. If anyone says they're not just right, I describe that as having altered mentation. They may be orientated to have GCS 15, but they're slow. They seem to have holes in their memory. Or the wife or relative says, look, he just doesn't seem right to me. I have the luxury of saying, well, that's okay, we'll just get a CT scan. We can get that done very quickly where I work. But that may well not be the case. If you're working rurally, then the only decision you may have is a prolonged period of observation or refer them on to a centre that can do a CT scan.
And if you don't have a CT scan, are there any examination, I mean, apart from your normal neurological examination that you do, are there any specific neurological tests that you can do that are more sensitive than that?
Not really. I mean, that's probably the most sensitive test is the relative says he's not just right. That patient may well have passed everything that you've got to offer. The GCS is 15. There's no motor deficit, sensory deficit. The coordination is normal and intact, but they're not quite right. And to make that clear, we CT those, but we don't really expect to find very many lesions on that, less than 1 in 100, perhaps less than 1 in 200 in those sort of circumstances. But as I say, we've got the luxury of being able to do it. And for us, it gives us the capacity also to say, it's safe for that person to go home. We don't think that they're going to come to any strife. Whatever concerning the relatives will improve with time, hopefully.
You work at Sir Charles Gairdner, so you'd see there'd be quite an elderly population that comes through as well. So I suppose the downside of doing a CT in elderly population is very low.
Well, it is. And I was just about to say that the normal mentation thing is not necessarily easily to apply in elderly people, and there are a large proportion of the people that we see that get minor head injuries, and it's usually just falling over from standing. For whatever reason. And sometimes they already have cognitive impairment. We do tend to rely on the relatives being able to tell us what their normal function is like, but we have a extremely low threshold to CT patients over the age of 65, and in the Canadian CT rules, for instance, 65 is one of the greater than 65 is one of their risk factors requiring a scan. And interestingly enough, in that study, if you read it, they didn't actually examine any patients over the age of 65. They excluded them from their study.
That's why it's not included as a criteria.
Well, their assumption, I think, is that they were going to be scanned, so we're not going to include them. We're not going to include them in the study. Yeah. And we now get patients, from nursing homes who've fallen over, hit their heads, referred in from nursing homes for a CT scan. The nursing homes are starting to catch on to that as well.
How many nursing home patients are playing sport, Roger?
Yeah.
Don't know what they do in their nursing homes.
Just a lot of them fall over and hit their head.
And they're on aspirin, and they're on warfarin, and they're on Plavix, or something
absolutely.
that's going to make them bleed. It's a no-brainer, really, isn't it?
So for us, if they've got a head injury over the age of 65, then the question is there any reason not to CT scan this person? Yeah. But as I said, we've got the luxury of having CT available 24/7. And the other thing with elderly patients, as I was mentioning before, we have to be a little bit cautious when they bump their head, is they tend to cover up injuries. They don't want to be a nuisance, or they just want to go home, and they'll tend to sort of gloss over whether they've lost consciousness or they can't remember the events. I've been caught out once or twice that way. So
sometimes they can't remember the events. That's the problem. Somebody will notice they've got a massive big shiner or something like that, and how'd you get that?
But talking about covering things up, Orla, I think that's sort of a common thing with sports players too, isn't it? They really, it's the semi-final and they've had a loss of consciousness.
Yeah, if you're involved in your semi-final, your local footy team are playing, and you want to be part of it, because if you're not part of the team, you're not part of the action. So, if you've had a concussion and have a persistent headache, when the doctor or the team doctor, if there is one, or you've had to go back to your GP and you want to get the clearance to go back on the field, you're going to lie through your teeth because you want to be on that pitch.
So I suppose if you ask them,
it is a bit difficult.
If you ask those patients, specific questions, they might lie about them. Yeah. But is there any more objective tests or measurements that can help the local GP, if you like?
There are, like in all the professional sides, they'll use, well, my sport is union, and I'm sure the Australian rules, and I know in the American football players, they all get neuropsychiatric evaluation at the pre-season, mid-season and post-season, and at any stage that they're involved in a traumatic event that results in traumatic brain injury. And they're all available online. There are tools that can be downloaded, and cheating is quite difficult. I mean, a lot of these guys would have a lot of time on their hands, and they'd be very good at computer games, so they're very good at doing all the sort of, whatever it's called, Nintendo type stuff, showing my age here. And but the tools are designed that they can trick people out. So the first minute will be very easy, click when you see this, is this red, is this yellow, whatever, and then it'll go on what was the number 2 before, what was the number 2 after, and things like that. So you can get tricked out. It's quite time consuming to do, though. It does evolve evaluating the scores afterwards and relate them to pre-test evaluation. Yep. So if you've got someone and you're in a rural setting, it's going to be quite hard. Right. Yeah, and you have to be very clever in your questioning and in your evaluation, and just be very honest with the player and say, and explain the risks. There is a real element to going back playing sport with a post-concussion syndrome, and you actually need to be fully recovered. If you're taking paracetamol for ongoing headache and not telling me you're going to go out and get another concussion, well, that all adds up, and I'm afraid you could have dementia or some form of post-traumatic encephalopathy by the time you're 30, and that's a problem, a real problem.
So you mentioned the word concussion. So what is concussion?
Well, I tell patients concussion is a syndrome after having a head injury, particularly one that is associated with loss of consciousness or amnesia or confusion. And characteristically in the early stages of it, you suffer mild headaches, mild difficulties in concentrating, to the point you might find it difficult to read, not for double vision, because just accommodating on a television or on text on newsprint. And that these symptoms, it used to be when I was training that we were told that the symptoms resolved in a week's time. They do resolve over time, but what I'm telling anyone with a concussion now is concussion is a lifetime injury. You'll carry that concussion may only be detectable on subtle neuropsychological testing, but you'll carry that concussion for the rest of your life.
Right. Yeah.
And every new concussion will be additional to that. I think there's good evidence emerged, most famously with American football players now, that they carry those severe concussion injuries for the rest of their life.
Basically with the concussion, as Roger says, so if they go on and do MRIs on, you know, if they're in the elite sort of sporting sector, it's basically a diffuse axonal brain injury,
Right.
which is only really detectable on high resonance MRIs.
So that's just sort of what, a shearing thing with? Is it microhemorrhages and things? Or?
Exactly, it's just like intraaxonal hemorrhages seen at very high resolution. So, you know, not every young kid, you know, you don't want to be scanning these young children every week or subjecting them to MRIs. So, and that's why it's really important as physicians, and particularly like we're very privileged to work in the emergency setting, and we can do these scans if needs be, is that you explain to people that, you know, it's really your life we're talking about here.
Yeah.
And you don't want to be suffering from things like Parkinson's and motor neurons. That they now actually believe in the studies they're doing on American football players that they could actually be pre-runners. All these repetitive concussion syndromes could be pre-runners to things like motor neuron disease as well as Parkinson's. So, so Roger's right in what he's saying to patients.
In these patients, we're talking about that diffuse axonal injury that, as Roger says, you sort of carry for life. That's not seen on a CT.
No.
Right.
No.
So it's just so a normal CT does not mean they've got a completely normal.
No. So
brain.
we're doing a CT really to make us feel better as treating physicians and to reassure the patients that, number one, they have a brain that doesn't have any significant major bleed, intracerebral bleed or extracerebral bleed, or any skull fractures. That's really all we can tell. We can't tell anything at the soft tissue level. Yeah.
Okay, so someone's got a minor head injury, but for whatever reason, you decide, look, I'm sufficiently worried about this patient that they get a CT. The CT is reported as normal. Yeah. That simply just says that they don't need to be sent to a neurosurgeon. Right.
That's true. That doesn't mean they don't have a significant concussion. It's, and that's a good point to make. I mean, some people might be reassured that, oh, my CT was normal, it was okay. Well, no, that's not the case. You still may well have a significant concussion, which is a serious injury in itself. It just doesn't show on a CT.
And while you use a CT as a tool to get patients out of your department, so normal CT, they can go home, I suppose. But would there be some patients with a normal CT that you would admit?
Oh, there are certainly some patients that have ongoing reduced GCS or cognitive dysfunction. Freaks the family out. They don't know what to do with. They don't know when to bring that patient back. That will admit them, mainly just, I guess, to make us feel more confident and the families feel more confident. There's not really much we can do in hospital to make their recovery quicker. But it's something that makes the family feel very uncomfortable. You know, he's talking gibberish still, even though his CT is okay.
That's what I was going to say with retrograde amnesia, and they were repetitively asking the same question over and over again. Where am I? What's happening? What's going on? It's really frightening, and they also tend to get quite hyper. I don't know if you've seen them. The individual with the head injury, it gets quite hyper and excitable, and so it's 2 o'clock in the morning. They're sitting up in bed, going, "Where am I? What's happening? What's going on? What time's tea?" And that's quite a frightening thing for the family. So yeah, if normal CT head basically just means there's no immediate neurosurgical threat to their life, but obviously they've got some underlying, they're suffering from a concussion syndrome, so you need to look after them.
So if someone's got a normal CT, what's the chance of them developing like a delayed bleed, like a subdural type thing? You know, we hear, about the chronic alcoholic, if you like, who has knocked his head, and a week later he's walking to the side and got poor balance, etc. You see TM and he's got a subdural.
It's often spoken about. I've never personally seen it. I believe it does happen, but it's quite rare. And there's this concept of we do CTs quite early in the patient's management. Does that mean we should repeat the CT again at some stage? I think the answer is no. If we're doing a CT because there's some mild, subtle signs to suggest that they require a CT scan, and that's normal, but the patient is clearly recovering, getting back to GCS of 15. I don't personally believe I'd be concerned that we need to keep that patient do another CT or to delay the CT scan. If a patient, however, as we discussed, has ongoing cognitive impairment for more than 4 hours, for 12 or 24 hours, that might be a case of doing another repeat CT scan. Having said that, I've never seen that.
Yeah, so
early
it's
normal
not
CT
something to
normal.
really worry
Yeah, I
about.
have to say in my experience, I've never, even with rugby union players, I've never really had them go on to require further CT. They generally get better.
So if something's
better
going to
within
be
the
there, will be
first
something
24 to
there on the
48
initial
hours.
CT.
I've
usually.
seen delayed, with the amnesia persisting for 48 hours or more, but never requiring CT. It always generally settles down within the first 24, 48 hours.
Excellent. Yeah. Okay.
Which is good.
So what about the patient who, for instance, is the local drunk and is always coming in
Playing
heavily?
football.
Well, he might be
He plays football when he comes into the
but
emergency department.
he repeat presentations to your local hospital with, and blows a very high alcohol level, so reduced GCS. And when you actually look back through his notes, he's
Gets a
had
CT every time.
10 CTs in the last year.
The devil you do, the devil you don't. Unfortunately, that's the way medicine's gone nowadays.
Yes.
So
Absolutely.
if he's an alcoholic, he's a high risk, and if he's had a mechanical fall or unwitnessed or brought in from the side of the
usually
road.
unwitnessed, yes.
And these generally happen, late in the evening or late at night in the middle of a busy shift. And while it's all very well to leave him sitting on a trolley with a GCS of 9, 10 or 11, it's your hat, it's your call. I'd be scanning him.
Yeah, absolutely. There's a very low
Difficult.
tolerance to missing an injury these days, even in the patients that are most at risk of getting injuries or are currently coming in, or chronic risk takers like alcoholics are always getting into scraps or falling over. I'd say if it's a situation where the clinician looking after that patient knew that patient well, had seen them in that condition before, it wasn't a concerning mechanism of injury, but they have got a bruise or a graze on their head somewhere. But they do seem to improve over time, as they might expect with that person sober out, having seen them before. That might be reasonable to observe that person. But if they're not known to you, and you can't tell whether or not they're improving, then the bottom line is to CT them.
Yeah.
But you probably would know them in a smaller community. You would
Yes.
probably know who your local repeat offenders were, and as Roger says.
But for a lot of patients,
if you're
that
more
would require
afraid
an
with them.
RTS transfer.
Yeah.
So in those patients, there would be appropriate.
To observe for a
Presumably,
period of time.
those patients would be to observe them, see what they're like in the morning. If they've got persistent deficits or any concerns, then you transfer them out
Yes.
for the CT.
Particularly if it's persistently remain at, if you're using the Glasgow Coma Scale as your assessment tool for monitoring the level of consciousness, well, then I'm afraid you have to do what's the right thing and protect the airway, breathing, circulation, organise a transfer to an area where they can do a CT scan.
It's always a hard call for
It is a
rural
very
doctors
hard call.
because the evacuation of the patient
Yeah,
involves
it's
a
a
lot of
major
resources.
undertaking, yeah.
But then I think they also have to remember that there's that delay involved.
Yeah.
So should there be something actually found on CT, then there's compounded by the fact that the patient is out of tertiary level care, if you like, during that period of time.
Yeah.
We'll hold that discussion there for just a moment. We visited Brightwater Care Group on Oats Street, and there we spoke to the team about the rehab services they offer and the range of recovery that can be expected after a significant brain injury.
Across Western Australia, every year there are about 600 people who would have a significant brain injury. Approximately 42% of them would have brain injury through trauma, through things like traffic accident. Then there's a whole raft of other causes of brain injury, including stroke. People may have tumours, people may have infectious issues such as encephalitis and meningitis, and people can also have other causes such as anoxic damage from heart attack or drowning. The range of services that are provided at Brightwater Oats Street predominantly focus around the community-based rehab program that we have here. So the services that we provide within community rehab are not only around basic life skills such as showering, dressing and mobility, but it's also skills that enable the person to access the community and organise and run their own life. So that may be how to cross the road, it may be how to use public transport, it may also be skills such as how you manage your money, how you actually cook meals, and skills around interpersonal relationships and managing some of the changes in emotions, so behavioural management, so you're less likely to become angry in certain situations and are able to control that. They're the main focuses of the program. It's about adding purpose and context to people's lives around their brain injury, so having meaning to them. But on top of that, we have a number of other programs that we offer, including life skill programs for people when they move out into their own home. We also have programs where we're teaching other organisations, so educational programs. We'll provide consultancy services to other organisations, both health and disability agencies. And we're also able to provide support to even mainstream services in the local community so they have an understanding about the impact of brain injury. So main focus is very much around that community-based rehab program, which does extend into rehab into the person's own home. But the other focus is about educating and upskilling other people so that they can continue to provide supports to people with brain injury in the community. Brightwater Oats Street has a strong interdisciplinary team. The interdisciplinary team is made up of health professionals such as physiotherapists and occupational therapists, social workers, speech pathologists. We have clinical psychology and psychology. We also have a very strong reliance on our registered nursing and enrolled nursing because those professionals actually have a strong focus on people learning how to self-manage their own health, which is really important in the long term. And then we have highly skilled disability support workers who are taught about rehabilitation, they're taught about people with brain injury and taught about taking a specific focus where they're able to step back and support only when they need to, but prompt the person to continue to gain skills and learn to do things by themselves. So the whole team works together and the whole team is really there to provide a total well-rounded input into goals and outcomes for the person, not just focusing on discipline-specific issues, but total outcomes for that individual.
Okay, maybe just one more. Maybe this one here.
Our main referral would be Shenton Park campus, so the State Rehabilitation Unit would refer people on once they've finished a 3-month period with them, 3 to 4 months usually. But we also have people who've been living at home for periods of time who aren't recovering as well as they or their families would want. They will get referred to us. State Head Injury Unit refers people through to us, and other advocacy agencies such as Headwest will refer people on to Brightwater Oats Street. Many people who come to us from the regions have either had a severe injury and are transferred through to the metropolitan hospitals. They will then be referred on to us from those metropolitan hospitals. We do have people who are referred to us from the country hospitals. Occasionally in the regional hospitals we'll go out to that regional hospital and do an assessment if we're able to do that, or we'll provide information to the clinicians and the practitioners over the telephone for them to provide us with information. And then we can jointly do an assessment of that person and whether they're eligible for the program. Once somebody has moved into the program from the regions, we then really have to strongly focus on how we can value add back into the region that they've come from, what other services are available in there, whether they're disability specific services or whether they're mainstream services or whether they're health focused. If we can actually build capacity within the regions, it not only supports that individual who's moving back, but will support other people with brain injury who are living in that area in the future and at that point in time. Because we're already in the metropolitan area, we can take people out to their local supermarket, we can take them to the bank, we can form connections with the chemist and the local GP. That's something that we find more challenging within the regions. So if we can link in with an organisation in the regions and provide them with the skills to do that for us, they'll be able to continue to grow and build on what we've already achieved with that individual at Oats Street. If we can also teach families to do that, then it gets reinforced even more. So you're looking at a 24/7 service, which is what we already provide here, rather than a service that's happening once or twice a week.
Have a deep breath and just relax your hand. Try that.
For families, often being confronted with supporting somebody with brain injury is extremely challenging. It's something where the personality of the person may have changed, the things that the family relied on that person to be able to do, or how they value added back into the family has now changed and sometimes been removed. So it's not only confronting, it can be devastating for the whole family structure, but also within the larger community. If that person, and this often happens in rural and regional areas, that person may have been a key part of that community, so there are changes in the relationships that that person finds as well. So for us, it's about very much about teaching the families about what to expect and what they can do to support that person through that. But if we can also provide education and support to other people within the region, so they also know what the family's going through and what they're experiencing and how they can act and react in a way that's going to be more supportive of that person. Even just simple things such as giving them time to answer questions. So if you go, for instance, to the local sandwich shop and they ask you what you want on your sandwich, whether you want a sandwich or a roll, do you want it cut in half, do you want it multigrain, or do you want it white bread, or would you actually like wholemeal, and then do you want salad and all the rest of the raft of choices that you get. For somebody with a brain injury to be asked that question and to have it rolled off in front of them is extremely challenging, and they're going to get stuck on the first part of it and not be able to answer the rest of the question. So as a simple example, it's about teaching people just to slow down, give the person time to process the information that they've been asked, and then maybe ask the questions one at a time rather than as a whole stream of questions. And that will apply to most things that the person is experiencing in the community. But it's also about valuing the things they can do and can bring back to that community, so once again they can have a role within their family but also within their larger community.
And our thanks to the team at Brightwater for their time. Now let's get back to our discussion with Doctors Roger Swift, Orla Lyons and Scott Teasdale.
So Roger, earlier we were talking about, certainly in the elderly population, that there's not much downside to doing a CT.
Mm-hmm. No,
what about for younger
Children,
people and
yeah.
children and repeat CTs, etc.?
Yeah, look, children are a particular problem. Young children, particularly those that need a GA basically to have a CT. I don't deal with those, fortunately, so I don't have to concern that problem. But in terms of radiation, I think if it's indicated, then we do the CT scan. A head CT scan is going to be in the order of, I know, 2 or 3 millisieverts, and compare that to a chest X-ray, which is 0.05 millisieverts. In a young person, the most at risk would be the thyroid, I guess, in that circumstance. But look, I think if it's clinically indicated in terms of risks and benefits, then we do the CT scan. And a good example now of that is we're finding that plain cervical X-rays are starting to fall out of favour, and it's not going to be too long before we stop doing plain cervical X-rays even on young people and just do CT scans.
It's like we've moved from, we don't do skull X-rays anymore, we do CT scans. It's the same thing, we're moving away from no cervicals to, if we're scanning the head, we'll scan the neck, Yeah, so I'll follow up with Roger about children, we tend to err on the side of caution with children, as we said, with exposure to the radiation for the thyroid. And we've though we've a low threshold, if indicated we do it, but we probably go down the pathway of observation.
So admitting them for observation would be
and to be honest with you, that's generally for parental sense of satisfaction. Because you generally know that, particularly, it might not be sports related, they might have, well, what's quite common, we see babies falling off, nappy change tables, being left unsupervised on a bed and rolling off a bed. So there's two sides to it. So basically, for the child to make sure they're okay and to give the parents a sense of relief. So we generally admit for 3 to 4 hours neuro observation, make sure the child is clinically appropriate, because quite commonly once a child is involved in anything that's in a traumatic brain injury or concussion, they will generally go to sleep for a protracted period of time, and then we're waking them every half an hour, and of course parents don't like their children to be woken. If they're asleep, they want them asleep. So they come into an environment where mom can sleep on the chair if she wants to, and the nurse is basically doing the supervision and the care. So at least it's a controlled environment, it's a supported environment, and then we can make a proper assessment and evaluation on the child. But again, low threshold. While we don't want to scan, if it's needed, we will. The problem with scanning young children is that they obviously have to lie very, very still, even though the actual scan takes a minute. So in the very young population that will require an anaesthetic, they would need to be actually put to sleep to have a scan. So again, another risk issue, and again, an area in the Rural Health Service, whether the GP feels comfortable or else has to call RFDS to do a transfer. So that again is a big issue. But if the child has regained consciousness and is appropriate, and mom and dad are just concerned, then it's best to err the side of caution and observe the child until they feel they're better.
Roger, you sent through some links to some documents, the New South Wales Health. I had to read through them. They're quite
Very
lengthy
good.
documents, but they seem really quite good. And there was one section for adult head injury and one section for child head injury. And there was quite a good little section there showing the good explanation for the risk of radiation involved in a CT. I thought that was quite well described, sort of saying that your lifetime risk of cancer is 1 in 3. And probably a 1 CT is the equivalent of the background radiation for 1 year. And so therefore it might increase it from 30% to 30.1%. So I think while we're sort of paranoid about the effect of radiation in the children and young people, and clearly they've got a greater lifetime risk, in the elderly that risk is quite low.
Particularly, we were just talking about head CTs and not chest or abdomen CTs.
Yep.
In a chest or abdomen, we're talking up from 10 millisieverts, 10 to 15 millisieverts, as opposed to 2 or 3 in a head.
Right.
So in a head, it's even a smaller risk. We prefer no risk at all, but
I had thought a chest wouldn't have much radiation because it's not solid.
no, it's still it's depends on what sort of study you're doing, particularly if you're doing if you're doing, I guess it depends on what you're talking about. What are we doing in emergency departments? A lot of patients in the community have low resolution or high resolution CT scans of looking for lung disease, and that's I'm not sure about the radiation of that, but we're often doing scans with contrast, looking for injuries to the great vessels or looking for a PE.
Yeah, okay.
So generally speaking, if we do a scan of the chest and ED, it's going to be up from 6 up to 10 millisieverts.
So therefore quite a lot more than what they're going to get for their CT head.
Yeah, that's right. That's right. Yeah.
And hopefully just doing a one-off CT head. You're not doing a CT head series, you know, particularly if it's just following an isolated injury. You know, the child has had an isolated injury, you're going to do a one-off CT, unless, of course, there's been some industry will believe that they will require further CT imaging. But if you're just doing one-off, hopefully it's not going to accumulate as you would do in like CT chests and abdomens for pathology that you find.
Orla, can I ask you about return to sport after a head injury?
Yes, difficult.
So someone's had a brief loss of consciousness. Maybe they have a few concussion symptoms. When can they return to sport?
Well, it all depends. Again, are we talking we'll talk professionally. So, as I said, union is my area. So, but I think it can relate to AFL and other soccer sports as well. So if they've got a post-concussion syndrome that they're not requiring any analgesia for, so just take the most common post-concussion is generally an ongoing headache. And if they've been symptom-free for at least a week or more, they generally will get away with being off full contact sport for 1 to 2 weeks. If they've got ongoing analgesic requirements, and they're required to be off the analgesic requirements for at least a week before returning, so that can take them up to 3 weeks. Again, if you're questioning their reliability, if they've got a notorious history of being unreliable, and you've done previous neuropsychiatric evaluations on them, then you have to go down that route and get them to do some some of the tests in order to make sure that they're actually okay. But on average, for a straightforward GCS 50, normal CT and no post-concussion syndromes, they're generally back a week later. If they've got ongoing symptoms for a week, symptoms, they'll be back 2 weeks later. And then, so you just evaluate them on an individual basis. There's no set guidelines, unfortunately. There's just been no papers or studies released to say this is when you need to go back, that's when. It's pretty much individually based.
So in general, they have to be completely normal for
symptom-free for a minimum of a week before they return.
And how are they meant to return to sport?
In the professional area, if they've basically been symptom-free, there's generally, there's been some studies done again in the States, I think it was ratified in the Zurich meeting in 2008, along with the sport concussion assessment tool, of a 6-day activity program. So once they've stopped taking their analgesia for their paracetamol, their dizziness has settled down, they start on a 6-day training program. The first day is generally completely low activity, so walking, nothing that's going to raise intracranial pressure or aggravate the symptoms.
While they've got symptoms, they have to have complete rest. So they're not allowed
rest.
to exercise, and that's physical exercise and brain exercise, is that right? So they just have to completely rest. Yeah.
Okay, computer games.
That's rest,
testing.
is it? Okay.
Well, that's what they do, or listen to music, and of course that's not resting their poor brains. Yeah, so once they're symptom-free, they go back on a 6-day graded program, which starts with low activity to non-weight bearing, to sitting on a bike, just low impact, lower limbs, and then gradually back to full play. To exercise, to running.
And did I read there somewhere about when they're returning that, for instance, weights training and resistance training is the last thing
completely, because
that can raise intracranial pressure.
And exacerbate their symptoms. Yeah. You know, if you're lifting a bench press 150 kilos and you start feeling dizzy and lightheaded, you know, that's just the pressure's too much.
Right.
Yeah.
Yeah. And then so really they should be fully recovered from their concussion, have a graduated return through training, and then they should be able to have a full training session. So at least a full contact training session before they return to actually active sport.
Yeah, and then the golden rule is once you think it's 100%, is give it another week. Right. So once you think that hamstring's back, you give it another week. Yeah. But of course, in the professional world, they're not going to give another week. Yeah. And in children, I would certainly err on the side of caution. I would definitely give them a week longer.
If we had, if we had a teenage boy playing contact football sport. Of whichever description, who has a concussion, misses a few weeks, then does all the training, etc., goes back, and a month later he has a second concussion.
Difficult.
And of course then he's there giving him advice about the rest of the season.
Yeah, well, probably should have the rest of the season off, definitely, and probably should be given the talk about and his parents as well, about the long-term consequences of repetitive post-concussion syndromes. You might consider, depends how good he is at sport, whether you want to go down the refer to neurosurgeon and have an MRI done. If he's a very highly skilled and has obviously got the potential to go on and play professional sport, you might consider that. But I'd definitely say the rest of the season off and then see how he is at the start of next season and do some neuropsychiatric evaluation on him and monitor him closely. Tough call. It is tough call to call on the young kids. You ruin their lives.
I suppose if he's passionate about his sport,
you can ruin someone's life, and it's a really tough call to make. But unfortunately, it has been shown at the younger age, when you have these repetitive injuries, they have a higher chance of, as this AFL footballers can't remember anything, or developing Parkinson's or something like that. Yeah.
So I suppose one strategy there would be to get them professionally assessed, and get the MR done and get some neuropsychiatric testing.
Absolutely, If you're going down that pathway where you're going to destroy some poor kid's life, I mean, because it is so important to them, particularly if they've got a potential for it. Yeah, big call. Not a nice one.
Was there anything else either of you wanted to bring up for our broadcast for our rural doctors today?
I was about to ask Orla what advice, the big thorny one, can be alcohol. What advice you give with people with a concussion syndrome regarding alcohol?
No alcohol. Yeah. No alcohol whatsoever. Yeah, no alcohol at all.
Until they're fit to return to sport, and then they have a big win, and then they sort of drink alcohol and come in after falling over. No alcohol. In the professional sports, it's just a complete no-no. They don't drink until, of course, they have a big win and then go out and destroy themselves. But with a head injury post-concussion, no alcohol whatsoever. Again, a hard one to, and no drugs, no drugs of abuse. The other thing I was going to bring up is a question of how long, if you choose to observe someone, how long do you observe them for? Those New South Wales guidelines would suggest 4 hours from the time of the injury. If at the end of 4 hours they're GCS 15 and they're talking and walking normally, then they can be discharged then. But it'd be particularly if you don't have easy access to a CT scan, you might have a lower threshold. So you might choose rather to, the drunken person has fallen over, rather than transfer them, you'll observe them for longer than 4 hours because it may take longer to sober up and be more sensible. I think if you're going to observe someone for a prolonged period of time, the crucial thing in that is that they should get progressively better over that period of time. So the drunken person, each hour, they're a little bit more sober, a little bit more sensible, and a little bit more themselves. If they remain as impaired as 4 hours later as when they arrived, then you start to get concerned. So we do find in drunk people that they do get better over time, and that's what we normally expect to see. If they don't follow that recovery, sobering up period, then I get concerned.
And neuro-obs as well. I mean, you bring people in for observation so they can be observed, and so that means they need to have neuro observations done. So and particularly in the rural, if I was admitting somebody, I'd keep them in overnight. That's because if it's a sports related event, it's generally going to happen on a Saturday or Sunday afternoon, and I'd have a really low threshold. I'd just admit them overnight and observe them. But I would stipulate half hourly neuro-obs, and that means temperature, pulse, blood pressure, GCS documented. And we have the traffic lights neuro-obs charts now in the Rural Health Service as well. So and that's for a reason. And so it's very important that as a medical person admitting someone, it's all very easy to put them onto your ward and then completely forget about them. Is that you need your nursing staff to undertake proper sets of neuro-obs and then to report to you, not to sit on them and say, oh, we'll see how they get better. So half-hourly neuro-obs for the first 3 to 4 hours, then on to hourly, and then 2 hourly, and then overnight.
So just document that very well.
Document a good plan, half hourly for whatever the period you're concerned about, then extend it to hourly, and then 4 hourly overnight if you think they're going to be okay. So unfortunately it's overnight that things happen. So you want to make sure that the nursing staff are perfectly happy that that person, particularly if they're intoxicated and not a sports injury person, that they've got a GCS of 15 and they're fully cognitively function, can go to the toilet independently, can feed themselves, drink themselves before they do go to sleep for the night, because that's when they don't wake in the morning is the problem. And you've observed them overnight, in inverted commas.
Yeah, it's rare, but sometimes with an acute loss of consciousness, you do actually have a seizure as well.
Oh, right, yes.
And with head injuries, it's probably worth mentioning because 1 or 2 people out may well have seen it. With head injuries, you tend to have seizures in 3 phases. You can have an immediate seizure, so you get knocked and have a seizure.
Yes.
That may be related to the concussion, may be related to a little bit of hypoxia because they're not breathing as well, being knocked out. Then if they're admitted to hospital, we might see seizures in the first week. That's some severe or serious head injuries. And then there are delayed seizures, those who have a little lesion on their brain and develop epilepsy related to it later. Those first seizures, the immediate seizures, are usually benign. Yes. They usually recover very quickly. They're short seizures, less than a couple of minutes, regain consciousness and recover within half an hour to an hour. I've seen footage of some players have seizures on the field, and I'm told that they actually played later on in the game, finished the game off, and don't remember the game. I think, however, although we think they're benign, that if someone's witnessed to have a seizure, they're probably going to end up having a CT scan. So if they've got a seizure, just start planning to send them off to have a CT scan.
So certainly an initial seizure associated with the head injury, you said it's normally benign, but probably does require a CT. But certainly a delayed seizure, delayed presentation, etc.
If they happen a week down the line, or generally with associated underlying lesions, it's more sinister. Yeah, but no, it's very frightening, particularly if you're on the side of a pitch and your player has a seizure. It's quite a frightening undertaking. If you're, if you're a lay person and you haven't dealt with it, it's very frightening. But they do tend to make a good recovery, and it doesn't cause long-term sequelae. But they shouldn't play on. We've seen quite a few lately. There's been a few on the Australian rules teams. I've seen at least 2 this season, just observing. So it's not something that's unusual. And yes, you will see them playing the following week.
So I suppose the old days of a quick test on the side and then back onto the field are over. If someone's lost consciousness, or if they've had any major head injury, that's them for their game. Yep.
Red vest, or they should be out the back on their way to hospital. Yeah.
And our thanks to Dr. Roger Swift and Dr. Orla Lyons for their time. Behavioural changes and cognitive impairment after a head injury can be difficult to deal with. We spoke to Headwest about the type of support they can put you in touch with to help you, your patient and their family.
Headwest have been around for about 30 years and have provided a wide range of services during that time. We currently support people throughout WA with our free service that's funded by the state government. And we focus primarily on individuals with an ABI, looking at key areas of their life that they need support with, key outcomes that they want to achieve. Another component of the work that we do focuses specifically on supporting families, carers and supporters of people with ABI. And our education and awareness is a key component that we've really ramped up in the last couple of years, whether that be education around ABI to health professionals, clinicians, service providers at the coalface who provide direct care, schools, parents, friends, people with an ABI themselves. Quite often that component and their understanding of their brain injury for various reasons is something that we do focus on, whether they forget, whether they've been misinformed or they've not been adequately informed, or their trauma was some time ago and they've then faced difficulties through their journey. We may need to revisit that. So we spend a lot of time doing one-on-one work, and also a big area is around employers, supporting employers to better understand ABI, better understand their employee. We know that community connectedness and people getting out in the community, having some meaningful life experiences is extremely critical for people with an ABI. If that doesn't occur over time, their experiences and their disconnectedness is really quite evident. We also focus on connecting people together. So it's about connecting people who are new to brain injury or new to trauma with people that may have gone through that experience in the past. It's quite often warming for someone to have a conversation knowing that that person has been through a similar experience, or their son or daughter has been through a similar experience. So that's another focus of ours around supporting families. And we have, in the recent year, a program around providing ambassadors out into the community. So people who have had a brain injury themselves or sustained some trauma, have a brain injury, who then go out and tell their story. And those human impact stories are really quite powerful when you've got a young person or a young male perhaps who's had a motor vehicle accident or had been assaulted, say, who then goes and talks to other young people about his experience and what his life now looks like or her life now looks like. Definitely our focus is, and our mantra is that we're community based first and foremost. So it is about supporting people once they're back into the community. We may meet them when they're in the health system or they're in that medical model, but our focus is that long-term support on allowing people to get back into their community, maintain connectedness and continue to live a good life. We know that for some of our clients that we see, what's been critical for them has been that at discharge from Metro or from leaving Perth, that their discharge plan, if you like, or their plan moving forward is well documented, and that key people are identified back in their communities to either be trained, whether that's over the phone, via video link, or via the nursing post, or via the outpatient or the local hospital, and that key people are involved, given some instruction to then support the family, support the individual and help assist to maintain some of that motivation. There aren't going to be a range of speechies, OTs, physios, the likes of a great wraparound service for people heading back to regional or remote areas. We know that, and failing large pots of money coming from somewhere, we know that's not going to happen in the near future anyway. So I think it's about how do we work together to work smarter, work harder if you like, by taking some of the expertise that may have been around that individual whilst they've been in Metro, and then try and duplicate it with anyone that's available in their community when they go home. For families to best support someone who's going through behavioural changes or displaying behavioural changes that they may never have seen before, is that they have to have the education, they have to empower themselves with the knowledge first and foremost. They need to understand it. So they need to understand that, we talk about the two changes, the cognitive changes and the physical changes. Some of the physical changes we can see and they're evident and, they're in everyone's face, but the cognitive changes are the ones that, create this ABI as being an invisible disability. But it doesn't mean that they're not there, and they will come out at all times, strange times when they shouldn't come out, when people least expect them. So they need to understand them first and foremost, or at least empower themselves with the understanding that there will be potentially memory problems, there will be poor concentration, there will be a lack of insight, there will be fatigue, there will be moments in the community or in social events where inappropriate stuff happens. Anyone and everyone can make a phone call to Headwest and we can look at what their training needs are, whether that be an individual, a family, a service provider, a local community group, anyone who has an interest and or is supporting someone who has a brain injury. Then it's about a phone call and we're looking at how we can get involved, how we can help them. We tailor our training. It is tailored generally around the cohort of people, whether they be, say, direct care providers that are working with a person with an ABI, or whether it's a family member, teachers. We quite often say to people, if you meet someone and you might say, or you might ask yourself, there's something not quite right with that person, or that person's not so sure about him, or last time I met him he wasn't like that at all. Then if you're talking about that and you're asking those questions, then have the conversation. Don't be ignorant, educate yourself, and family members, the individual with a disability, with an ABI or disability themselves will tell you, and they're happy to tell you their story. Quite often and not, that's quite empowering for them as well, and it's quite therapeutic. So we ask everyone in communities particularly to just have those conversations. If there's been a family or a community member that's had an accident or had a fall or whatever, had a stroke, had a heart attack, near drowning, a neurological disease, Parkinson's, got MS, something like that, then that's a brain injury, and there's conversations that need to happen with the primary carer, maybe with the employer, and if we don't have conversations with everyone involved, we know that the person with an ABI will end up isolated and have some poor life outcomes.
And our thanks to all our guests in tonight's programme, Dr. Roger Swift, Dr. Orla Lyons and Dr. Scott Teasdale, and of course the teams from Headwest and Brightwater. That's all we have time for in this programme, but before we go, here's some information about the upcoming Rural Health West Fremantle Conference from Rural Health West Events Coordinator Lisa Thomas.
The Fremantle Conference is taking place at the Fremantle Esplanade Hotel by Ridges on the 19th of October. This year the conference will include 4 different workshop streams. The streams will be anaesthesia and ultrasound. There'll also be an emergency medicine, a women's and obstetric emergencies, along with a surgical practice update. Each workshop stream is limited to 15 delegates and will be a Category 1 ALM. Applications have been made with the professional colleges so that eligible doctors can receive the $2,000 procedural grant if they attend the conference. Registration is limited to 60, so if you do wish to attend, we urge you to get in quick. We hope to see you in Freo in October.
Thanks, Lisa. And if you'd like any further information about the Fremantle Conference, please visit the Rural Health West website. While you're there, you can follow up on some of the resources mentioned in today's programme. You can find links to the article on sports-related concussion and to policies for the management of closed head injuries in adults and in children and infants. The website is ruralhealthwest.com.au. We're back on the 8th of October with a program focusing on travel medicine. I'm Jerry Gannon. Thanks for joining us.